I'd like to get to our first speaker. I'm not sure that this gentleman even needs an introduction, but it is my honor to introduce Dr. Jeffry Life. When I first met Dr. Life, I honestly didn't know what to say to the man. I had the pleasure of meeting him many, many years ago, and I just looked at him and said hello and walked away because I really didn't know what to say. But as an introduction, Dr. Life is a course co-director and a faculty member of Synergenics Education and Research Foundation. He's the founder and CEO of Life Center of Healthy Aging, an affiliate of Synergenics Medical Institute in Las Vegas. He completed his physician training and certification in age management medicine. He's a diplomat of the American Board of Family Practice and fellow of the American Academy of Family Physicians. In 2007, he was the first ever recipient of the Alan Mintz Award for Clinical Excellence in Age Management Medicine. A lot of you have also seen him at the booth. He is the author of this new book, The Life Plan, How Any Man Can Achieve Lasting Health, Greater Sex, and Stronger Lean Body. And for those of you that haven't seen this book, you need to get a hold of it. It's a fascinating read. It's my pleasure and honor to introduce our first speaker of our conference, Dr. Jeffry Life.
Very good. Well, thank you, everybody. And I want to thank Greg and Rick for another spectacular meeting. This is our 10th meeting, and this is the first time we've ever been in this building, and this is really pretty spectacular, I think. Well, this morning we're going to start out at 8 o'clock a.m. and talk all morning about men's sexual health. I must point out to you that it's 5 a.m. in Las Vegas, where I'm from. So it's a little early to be talking about all this, but that's what we're going to do. First, I want to start with a history of sexuality in America. It's very, very interesting, I think. It goes way back to 1832, when Dr. Charles Knowlton was put in prison because of his book, Fruits of Philosophy, which promoted birth control. This was kind of a turning moment in America's history when it comes to sexuality. In 1973, the Comstock law was passed, which forbid any literature being sent in the mail that discussed birth control. It was considered to be obscene. In the late 1980s, Margaret Sanger, a nurse, started to change the way everyone thinks about birth control. And she started a movement, and in 1916 she opened the first birth control clinic. She was immediately put in prison for 30 days. But that didn't slow this lady down, because by 16 years later, she had, how many? 80 clinics scattered throughout the country that dealt with birth control. So she was a pioneer in getting us to change our attitudes. In 1936, the majority, missed one. By 1936, the majority of medical schools in this country did not teach anything about contraception. Sort of like today, they don't teach much about exercise and nutrition. In 1937, the AMA officially endorsed birth control. I got in just under the wire. My mother was pregnant when she heard this information. So I slipped through. In 1942, 800 birth control clinics were scattered throughout the country. In the late 1940s and 50s, women were married much younger than ever before, and they were having children much sooner than ever before. And then Hugh Hefner came along, 1953. And he published the first issue of Playboy. And this began to change the way America thinks about sexuality, not particularly in a good way. He considered that there would be no limits on sexual expression, and he was very much opposed to marriage. In 1960, the FDA approved the pill, 3 years after I graduated from high school. Just thought I'd throw that in there. In the early 60s, Helen Gurley Brown wrote a book called Sex and the Single Girl, and this began to change the women's attitudes about sex, promoted sexual freedom, discouraged marriage. So she kind of took over the female side of where Hugh Hefner was going. In the mid-1960s, anti-establishment, Vietnam, music, drugs, different modes of dress, sexual freedom. In the late 60s, hit the hippie movement. I was all part of this. I wasn't part of total sexual freedom. Dear. Marital infidelity. In 1969, Woodstock, the play Hair, the New York Times said a new, more permissive society was forming in America. In 1969, there was a birth of two organizations or two movements, the women's liberation and gay liberation. In 1973, Roe versus Wade, that's almost 40 years ago, the Supreme Court just surprised everybody by allowing abortions to occur in states as long as they were done by a physician. At the end of the 70s, more than 25% of married women in their late 20s remained childless. In 1960 to 1980, marriage rates declined by 25%. Divorces increased by 200%. And the divorce rate itself jumped to 90%. And I can tell you that all the couples I knew back then are not together. In 1960 to 1980, men and women became sexually active earlier in life. In the 1980s, there were debates about sex. All the debates about sex were polarizing this country. In 1980 and 81, we had the first signs of a horrible disease with men coming down with pneumocystis pneumonia, gay men. In 1981, 255 people died from AIDS. That worked its way up to 40,000 in 1987. In 2007, there are almost 600,000 people living in this country with a diagnosis of HIV. That number is way under what it really is. It's estimated to be over 1 million because of the different ways states report HIV, because there are now home tests that people can do to diagnose HIV on their own. We still have 18,000 people a year die in this country from HIV. Starting in the 1990s till now, we began to get rid of the liberal attitudes about sexuality. Sexual expression has moved away, and now it's more back towards marriage. The gay and lesbian movement continues to be in full force, even though the religious right is trying to stop it. Men claim to have more sexual partners than women. Women experience orgasm less often than men. Men overestimate the number of times women have an orgasm. There's no surprise there. And in March 27th, 1998, the FDA approved the pill. This changed this country and the world, I guess. Wait. Well, they approved the second pill, the blue pill. Got ahead of myself here. And this has changed the world. And this leads me into erectile dysfunction. So I thought it'd be really kind of neat to give you a history of erectile dysfunction. It goes way back. Well, it's always been considered to be not organic up until the last 25 years. In the Middle Ages, erectile dysfunction was considered to be a sign of possible demonic possessions, and you had to be cured by exorcism. In the early to mid-19th century, ED was considered to be the result of masturbation or of too much sex, and it was cured by anti-masturbation belts. And if that wasn't bad enough, prosthetic urethral electric stimulation. I don't think you'd want to tell people you had ED back then. Sigmund Freud thought it was a mind and body thing. Masters and Johnson thought it was behavioral. In 1974, penile implants were created and released to the urology world. And there was a lot of excitement about these. But the insurance industry was afraid that they would be inundated with men lining up at urology clinic doors to get these penile implants. So they required some things. They required a proof that this was an organic problem. And so they required hormone profiles, penile Doppler studies, nocturnal penile tumescence studies, penile angiography, cavernosometry. All of this was required to document organic dysfunction. As you can well imagine, not a whole lot of people went through this, so the deluge of implants really never came about. But the end result of all that was positive, because we learned that ED was strongly associated with cardiovascular disease as a result of all this testing. Before the pill was released, the U.S. By the U.S. FDA, the urologists were really the guys that dealt with ED. But once Viagra was released, which is a phosphodiesterase type 5 inhibitor, that in 1998, by the end of 1998, only 15% of those prescriptions were written by urologists. All the others, 85%, were written by general practitioners, internists, primary care doctors that had really not had but very little training, if any, in medical school on male sexual function. ED continues today, however, to be perceived by physicians and patients as a quality of life issue, not an organic issue. And in today's insurance world, primary care physicians just do not have the time to spend with their patients to really get to the root cause of their ED. So they just hand them a prescription of Viagra or Cialis or Levitra. There's also still this issue that it's quality of life, not organic. So 25% of men with ED end up not being treated. Today, 52% of all men aged 40 to 70 have some degree of ED. In age management medicine, we are in a really unique position to really get at the root cause of sexual dysfunction in our patients, because that's one of the main reasons they come to us. And we have time to sit and talk with them. This is the beautiful part about what I do and what a lot of people here do. We have the time to sit down and talk to our patients and find out why they're there, what their goals are. And if you really keep talking to them, ED rears its head. most of our patients, I think, come to us because of sexual dysfunction. I think, low energy is one of the biggest reasons. But if you really start teasing it out, sexual decline in sexual function is a huge reason our male patients come to us. Sexual activity is a cornerstone of quality of life for most men. A decline in libido and sexual function is often preceded by erectile issues. I think we must really ask each of our patients about their erectile performance. It's got to be a key component of our evaluation. So how do we do that? With the SHIM test. How many of you know what the SHIM test is? Not very many. Well, there's the link, and here's the test. Need binoculars. Okay, this is a 5-question test. He doesn't want me to go into that side. 5-question test. First, how do you rate your confidence that you could get and keep an erection? So, if it's really low, the higher your number, the better off you are. But if it's really low, you get a 1. If you have no problem at all, you get a 5. When you had erections with sexual stimulation, how often were your erections hard enough for penetration? Here you can actually get a 0, on up to 5. During sexual intercourse, how often were you able to maintain your erection after you had penetrated your partner? Once again, you can get a 0 on up to a 5. During sexual intercourse, how difficult was it to maintain your erection to the completion of intercourse? 0 to 5. And when you attempted sexual intercourse, how often was it satisfactory for you? 0 to 5. Really simple questions. And once your patient has really a sense of confidence in what you're all about, they will answer this honestly. The best you can do on this is a 25. So if you are between 17 and 21, you have mild ED, on down to 1 to 7, severe ED. So this is a questionnaire that I ask all my male patients. The crucial question then is, if your patient has ED, is the ED a quality of life issue, or is it a possible diagnosis of early vascular disease? Almost 90%, this is from the American Journal of Medicine, 2007, almost 90% of men with ED have at least one risk factor for heart disease. It can be metabolic syndrome, high blood pressure, elevated cholesterol. These are all parts of the metabolic syndrome, as you know. Diabetes or smoking. 50% of men with diabetes have ED. Men with diabetes are 3 times more likely to have ED than men without diabetes. Men that were sedentary, in other words, did no vigorous activity for at least a month, which I find inconceivable. But there are people like that out there. And they come to us. And if they fall into this category, they were much more likely to have ED than people that do something, that move around during their days. The penis is a sensitive hydraulic organ that is responsive to sympathetic and parasympathetic tone, active vascular flow, and a passive veno-occlusion. It is composed of an extensive endothelial surface interlaced with smooth muscle. The entire erectile process is exquisitely sensitive to the availability of both neuronal and endothelial nitric oxide. Nitric oxide production is in turn totally dependent on the presence of both neuronal and endothelial nitric oxide synthase. the crucial enzyme that's responsible for the production of nitric oxide gas. The penis has a vast endothelial system that is a natural repository for nitric oxide synthase. Any disease process that reduces the levels of neuronal nitric oxide synthase or endothelial nitric oxide synthase will decrease erectile function. A reduction in neuronal nitric oxide synthase is usually iatrogenic, prostatic surgery, pelvic surgery, radiation, whereas the condition that results in endothelial nitric oxide synthase levels being depleted are related to the same processes that cause cardiovascular disease and endothelial dysfunction. So here's a list of the neurologic or the neuronal nitric oxide synthase conditions: surgical trauma, pelvic radiation, accidental trauma, neurologic diseases, endothelial disease, metabolic syndrome, hypogonadism, that's right, low testosterone levels, age, can't do a whole lot about that. Everybody ages. The whole key is to not get old. That's in my book. Hypertension, hyperlipidemia, diabetes, obesity, and smoking. Testosterone is inversely correlates with the severity of atherosclerosis and has beneficial effects on the vascular reactivity and so on. You can read that. Men with established coronary artery disease have reduced testosterone levels. Endothelial dysfunction is now recognized as the root cause of atherosclerotic plaque formation. The smaller vessels become occluded much faster than the big vessels, which just makes common sense. And the smallest vessels are the ones that go to the penis, and that's why that organ is the first to show signs of endothelial dysfunction. That happens way before you start getting blockages of your coronary arteries, your cerebral arteries, on and on, retinopathy, hypertensive cardiomyopathy. Erectile dysfunction is the body's early warning system. It's like the tip of the iceberg when it comes to endothelial disease. So when assessing a patient of ours that's 52 years old, and you're putting him on the right diet, the right hormones, getting his hormone deficiencies corrected, when you're implementing an exercise program, and he has ED, and he has lousy lipids, his ED, his endothelium is just screaming for more attention. And I think it's our responsibility to address that. In a large group of over 9,000 men in this prostate cancer prevention trial, ED was found to independently predict cardiovascular disease at a rate similar or even greater than found in smokers, patients with a strong cardiovascular family history, or hyperlipidemia. ED should be viewed as an early warning sign of silent vascular disease until proven otherwise. So the bottom line, ED is an easy way to assess the severity of a man's total endothelial disease and the likelihood of his having an MI or a stroke later in life. The Princeton 2 consensus guidelines highlights this whole role, and I gave you a reference for that. Men with ED, unexplained ED, should be treated as a cardiovascular disease patient until proven otherwise. This would include vascular studies, exercise stress testing, and what have you. Maybe a referral to a cardiologist. let's talk about the phosphodiesterase 5 inhibitors, which would include first Viagra, then Cialis and Levitra, and then there are several that are in the works right now. This is an article that talks about the combination of testosterone replacement therapy and the phosphodiesterase type 5 inhibitors. And they conclude that endothelial integrity has a paramount role in protecting a man from cardiovascular disease and genital organ injuries. These PDE5 inhibitors decrease the breakdown of cyclic guanosine monophosphate in the smooth muscle cells, thereby enhancing downstream effects of nitric oxide. And both ED and endothelial dysfunction respond to these agents. The PDE5 inhibitors not only favorably affect erections, but they also hold significant promise for improving overall endothelial function, because the PDE5 inhibitors impact the entire vascular system. And this hope is based on studies that have been done that have shown this when it comes to asthma and some other diseases. So on the basis of the currently available evidence, it is possible now to hypothesize that endothelial dysfunction may be modulated by daily dosing of the phosphodiesterase type 5 inhibitors. And this is what a lot of people, doctors are doing to treat ED. But we can speculate that the treatment of these men with long-acting daily dosing, Cialis 2.5 milligrams a day, may represent a future strategy for reducing the extent of coronary artery disease, or maybe even reversing coronary artery disease and preventing heart attacks and strokes. We know that single-dose administration of Viagra, for instance, increases the endothelial progenitor cells, and these repair the endothelium. So the bottom line is we know that testosterone supplementation and the phosphodiesterase type 5 inhibitors given on a daily basis show great promise in remodeling the whole vascular system. How can we assess the health of the endothelium? There are serum markers. There's endothelium type 1, endothelium. There's interleukin 6. There's tumor necrosis factor, and there's a C-reactive protein. These are serum markers. There are cellular markers, endothelial progenitor cells. There's imaging. There's the CIMT, carotid intermedia thickness, abdominal and femoral ultrasounds, calcium scores. There are physiological measurements, flow-mediated dilation of the brachial artery. That's abbreviated FMD, so you'll see FMD studies. There's this new approach, the peripheral artery tonometry, PAT, and finally there's the ankle brachial index, which is a really simple test where you measure blood pressure in a supine patient at the arm, and you measure it in the ankle, and you do a ratio. The EndoPAT 2000 is the instrument that measures the tonometry. It's FDA approved. It measures reactive hyperemia. It pump up the blood pressure cuff for 5 minutes, then release it, and then there's this reactive hyperemia, and that's converted into an actual number. A finger probe assesses the changes in volume after you release the blood pressure cuff. There's the machine. It gives you an RHI number, and this is the way the data looks. Endothelial injury, the common link between ED and cardiovascular disease. Hypogonadism, diabetes, hypertension and smoking, metabolic syndrome, vasoconstriction. This all creates endothelial injury. Vasoconstriction, atherosclerosis, increased autonomic activity, thrombosis. All this results in ED and cardiovascular disease. I was talking to my stepson, who is 21, about cigarette smoking. And I said, do you know that cigarette smoking can give you erectile dysfunction? He said, no. I said, yeah. If you ever decide to light up a cigarette, you got to think about that. Then I thought, maybe we should change the label on the Surgeon General's warning. I would think that'd get young guys' attention. Certainly would have gotten mine years ago. But it's a major cause of erectile dysfunction in young men. And then if you tell them, and that's just the precursor, that's leading you down this slippery slope to a heart attack or stroke. I don't know they pay much attention to that, but they definitely pay attention to this. This is just some more showing how you can improve endothelial function through glycemic control, statins, diet and exercise, aspirin, smoking cessation, the phosphodiesterase inhibitors, and testosterone replacement. These are the different references. So the overall impact, improvements in endothelial function, improvement in cardiac blood flow, and improvement in erectile dysfunction. Okay, what about growth hormone? Well, Conti wrote this paper a few years ago, and they believe that growth hormone plays a huge role in preserving endothelial function and preventing endothelial dysfunction. They even go so far as to say IGF-1 should be looked at as an independent risk factor for endothelial disease and cardiovascular disease, separate from all the other things we look at. So this is super interesting, I think. I gave a whole talk last time about growth hormone and how we test for it. How about growth hormone and stroke? Denti showed that there's a tremendous relationship between IGF-1 and how people respond to a stroke and recover from it. There's a potent inverse relationship between IGF-1 and the outcome of people that have strokes. For each 20 nanogram milliliter increase in IGF-1, the mortality risk was reduced by 30%. 20 nanograms is not very much. It's amazing. So how do I evaluate endothelial function in men presenting with ED? The DEXA. The DEXA, as you know, looks at bone density and body composition. It is the gold standard. It measures muscle mass to the gram, body fat to the gram. And it's very accurate, very accurate. Laboratory testing, C-reactive protein, testosterone, total and free, estradiol, dihydrotestosterone, LH, IGF-1 to assess growth hormone status, lipid panel, hemoglobin A1C, homocysteine, 24-hydroxyvitamin D. Specialized testing. I do the EndoPAT 2000. I do a CIMT, abdominal and femoral ultrasound and ankle brachial index. If the RHI score is less than 1.8, that's the EndoPAT data that cranks out a number. That means they have endothelial dysfunction. And so I attack it with lifestyle modification, diet, exercise, programs, daily phosphodiesterase inhibitors with 2.5 milligrams of Cialis daily, statins, niacin, aspirin, vitamin D, 5,000 units. And if they have more than two or more cardiac risk factors, I consider sending them to a cardiologist. Vitamin D. As all of you know, I'm sure, we thought vitamin D was not a big deal. We were trained that, no, you don't want too much vitamin D. It's toxic. It's one of the few vitamins that's toxic. And if you're out in the sun for 20 minutes, just your arms and face, you're going to have plenty of vitamin D. I can tell you every single patient I see is either deficient or insufficient levels of vitamin D. And here's an article about African American men that receive 60,000 units of vitamin D a month, and it improved their endothelial function. Vitamin D is a key part of how you treat endothelial dysfunction. So in conclusion, don't think this is over. I have another part, so don't start wrestling around. Approximately 34% of men who present with ED will have some degree of endothelial dysfunction. Endothelial function correlates with peak systolic blood flow and RHI scores, and help predict which patients are more likely to have arterial insufficiency. Low testosterone levels are associated with endothelial dysfunction and may be the underlying cause leading to erectile dysfunction. Given that endothelial dysfunction is reversible, early detection is critical and can reverse ED and prevent coronary artery disease. There are studies now underway to assess the impact of testosterone replacement therapy and other treatments, mainly the phosphodiesterase inhibitors, on preventing coronary artery disease. I asked my cardiologist about this, and he said, Jeff, I don't have time to delve into this. I don't get paid for doing these studies. And he's a great guy. I mean, he's got a busy practice. He's a very nice guy. I think the world of him. But that's the problem with traditional medicine. Doctors aren't compensated for the time they need to spend to get to the root cause of all this. And then I said, well, have you ever put any of your patients on daily Cialis? Nope, that's too much on the fringe. So I said, well, I'll let you know how it works. I think it's our responsibility as age management medicine physicians. We really have a unique opportunity to attract men into our practice that come in for lots of reasons. But one of the biggest reasons is they have sexual dysfunction. They've noticed a decline in their sexual energy or their sexual ability. And we need to tease out whether that's related to ED. Once we have, then I think it's really our responsibility to make sure that this ED is not because they have endothelial dysfunction. If they do have endothelial dysfunction, then it's paramount that we stop the progression of this disease and prevent heart attacks and strokes, which kill over half of us. Okay, fitness and sexual health. Having sex 3 times a week serves as a benchmark that you're healthy and physically fit. I should say at least 3 times a week. This is out of my book. Active, vigorous sexual function is like any other athletic activity. The more strength, endurance, and flexibility you have, the better you are at it. Here are some lessons, sexual fitness lessons. Passionate sex requires higher levels of physical fitness. Sex is a form of physical exertion that can be harmful to men with advanced heart disease if they are not in shape for the activity. In a study of healthy married men ages 25 to 43, foreplay took 3 to 6 minutes and orgasm lasted 16 seconds. So let's say 6 minutes and 16 seconds you can get a workout in. And they achieved a heart rate of 127, which is 67% of their max. So you get high intensity. So how do you improve erectile function? Improve cardiac function, improve lipid profile and other markers of disease, prevent or reverse fatness, improve strength and flexibility, improve self-esteem, improve relationships, and for me that should be relationship, honey. Correct testosterone deficiencies, and consider phosphodiesterase type 5 inhibitors daily. Body fat and erectile dysfunction. The 2003 Harvard study looked at over 30,000 men. BMIs of greater than 28 had more than a 30% higher risk of ED than those with BMIs less than 23. I'm not a big believer in BMIs, but it's the best we have to look at populations of people. But it's very deceiving because the BMI, as you know, is kind of an approach to assess what really is killing people. And what really is killing people is not how tall they are or how much they weigh. It's how fat they are. So fatness really is what we need to look for. And that's why the DEXA scan is so good, because it really tells grams of fat and percent body fat. 80% of men with moderate to severe erectile dysfunction are overweight or obese. In my experience, men with a greater than 20% body fat are more likely to have ED. Do you know what your percent body fat is? I think it's important everyone know. The harder you work out, the better your erections will be. And this exercise program should include resistance training, cardio, and functional fitness, balance, flexibility, and core work. Functional fitness would be bending, reaching, swinging, pushing, pulling, Pilates, yoga. My executive assistant likes this Bikram yoga. It's hot yoga. The jury's out for me on that. But I was talking to someone, one of the docs here, and he says he loves it. How many of you have done Bikram yoga at 105 degrees? Wow, that's impressive. I don't know. I'll have to try it. For me, martial arts, Taekwondo has really changed my life in the last 2 or 3 years. Flexibility, the most important component of sexual fitness. The component that is most ignored. As men age, flexibility is the first thing to go. A flexible man is a sexual man. Shane Gagne. Shane Gagne is my Pilates instructor. And she told me this when I first started, and I was stiff as could be. I said, really? A flexible man is a sexual man? So I really bought into this, so I've been doing Pilates 3 times a week pretty religiously. And this is Shane, and this is me doing lunges on the reformer. When I first started, I couldn't even begin to do that. If you look way in the back, you see a little tiny face, and that's my wife taking the picture. And I have 42 minutes left. No, I'm not done yet. And let's not forget Kegels. Kegels. I know, this is a male lecture. How many of you were ever told Kegels are good for men? Kegels are great for men. To strengthen the pubococcygeus muscle. So how do you know how to do that? Well, there are 2 ways to find out. Start your urine and stop it. Start, stop, start, stop. But a word of warning, if you have trouble starting it to begin with, don't do that. The second way is to go out to California, like today, and walk out into the Pacific. And when you get up to your waist, you will have contracted your pubococcygeus muscles. So, Kegels are great for men. It improves ejaculatory control. It makes erections stronger and harder. And you can crank out Kegels anytime. You guys can do it right now. Shall we take 10 seconds to do 10 Kegels? You can do it at the traffic light. You can do it during lectures if you get bored. And you should start out, and you should do this several times a day. 10 reps. It takes about a month before you start to see benefits from this. Well, what kind of Kegels do you want to do? Well, there are variations of Kegels. There are the SKs. These are the slow Kegels. You tighten and hold for a slow count of 3, then relax and repeat. Do that 10 times. That's the SKs. I gave these little abbreviations. The QKs are quick Kegels. Tighten and relax. Do as many as you can in 10 seconds. Then the big move Kegels. Tighten your entire abdomen and pelvic floor, and then force the pressure toward by bearing down. You got to be careful when you do that. And last, and I got to tell you, this is really a tough one. The fluttering Kegels, FKs. It takes a lot of practice. It takes more than a month to get expert at this. Now, how do you test the strength of your PC muscles? Well, you can pull back from the brink of orgasm. Or you can do the towel test. And this is where you hang a towel on your erect penis and you move it up and down. I would suggest you start with maybe a washcloth or maybe a Kleenex. And then you can work it up to a beach towel. Goal is 100 reps. But if you do this, you got to give your PCs a rest. So, and that's it. So now we have lots of time for questions about anything, this topic or anything else you want to ask me. I think they want you to go to the mic. So it gets all recorded, you know.
Thanks. Great presentation. The ankle brachial index, what should that be? The ankle brachial plexus, what should that be?
I think 1 or greater, right?
0.91 to 1.3.
There you go. 0.91 to 1.3.
Thanks.
Mm-hmm. Stephen.
Yeah, Jeff, I wonder whether your cardiologist colleagues are really looking at Viagra as a treatment for coronary vessel disease.
They are not. They are not.
So
based on my conversation with my cardiologist.
What about those 66% of men who have erectile dysfunction without having endothelial dysfunction? What would be the cause of it?
Psychological. I mean, there are guys that just don't have very good erections because of relationship issues. Once I rule out endothelial function, then I send them to a psychologist if it's not related to their endothelium. After I try to talk through it and figure it out. Well, and low testosterone. I mean, you can have great endothelium, and if your testosterone level is 200, 250, that's definitely going to give you issues with libido and your ability to have erections.
Yes, what was your maintenance level of vitamin D that you used, and how often do you check that?
I use, my patients are on vitamin D3 at least 5,000 units a day, and maybe a third are on 10,000 units, and I check their levels every 3 to 4 months.
Is there any relationship between Viagra and migraine?
Well, it can cause migraine. In all the phosphodiesterase inhibitors, when taken at their max dose, cause side effects: nasal congestion, headache, blindness in some people, loss of hearing. But the max dose for Cialis is 20 milligrams. 2.5 milligrams every day, people don't notice anything, except their erections are better, and a couple of my patients, their exercise performance is better, which speaks volumes, I think.
Does exogenous oxytocin help the performance and enjoyment in the man?
I have no idea.
Do you include adrenal assessment in your erectile dysfunction assessment?
What kind of assessment?
Adrenal?
No. Well, we do morning cortisols, and that's it.
Dr. Life, would you still consider using daily phosphodiesterase inhibitor for people that are on nitrates as well, even though it's contraindicated?
No.
Good morning. I have two questions.
It's an absolute contraindication. I don't know of anyone that would even test that out. You all know that if someone's on nitrates and they take a phosphodiesterase inhibitor, they can really drop their blood pressure way down. So, and so anyone that's on a daily Cialis needs to tell if they start having a problem and end up in the ER. They got to tell them right off the bat.
Good morning. I have two questions. First is there any relationship that you've ever heard between the use of statins and loss of libido?
No. I have a lot of patients on statins, and it doesn't... I think I had one guy that felt Lipitor was hurting his libido. But maybe, I don't know of any documented studies that would support that. And in my experience, if it happens, it's very rare.
Okay, secondly, use of arginine over the counter, let's say Walmart brand, patients have asked me about that, 500 milligrams, in a pill or whatever, taken orally before bedtime, after meals, etc. Is there any guidelines that you know of?
No, but that has been shown to really help erectile and performance.
Any dosage regimen that you know of?
Say?
Any dosage
No,
that you...
I do not know.
All right, thank you.
Dr. Life, that was an excellent and very practical lecture. I've been treating lots of men with erectile dysfunction for many years, and I talk to my heavy smokers and I tell them that erectile dysfunction is basically angina below the belt.
That's perfect. That's
I've
great.
been telling them that for 10 years.
That's great.
I've been going to lipid meetings. Any comments on the use of Bystolic off-labelly? Because that's supposed to increase the endothelial amount of nitrous oxide.
No, I do not know anything
I've been
about
using it. It's
And
an
you've-
off-label use.
You've had good luck with it?
It's supposed to augment, but it's off-label. I've been using Bystolic, especially for my men that have high risk factors with comorbidities, people with metabolic syndrome, bad lipid profiles, in that special situation. Do you have any comments on using any other particle studies like NMR or advanced lipid panels?
You mean like the Berkeley and the Cleveland Heart Lab?
Yeah.
We actually do that, and that's just another really sophisticated way to get at markers of inflammation going on in the vasculature. And if you then target your treatment to suppress that inflammation, you can see the changes in those markers. So I think it's an excellent way to, once you have a patient that you know has vascular disease, based on the initial history, the erectile dysfunction questionnaire, and then you do some of these studies of the CIMT and ultrasound of the abdomen and femorals, then I think you need these very sophisticated blood studies to pick up inflammatory markers that we don't normally look at.
In my women who have urinary incontinence, Kegel's exercises are always supposed to be your foundation. There's a product out there called the Kegel Master that's sold, through the internet. I never got the concept, and I'm so glad you brought it up today, on the pubococcygis muscle exercise for men. I thought that was very good.
Thank you.
Very practical. Thank you.
Morning.
Hello.
For men with ED, have you looked into pudendal artery imaging?
No. I talked to my urologist about this, about what he does with ED, and he just puts people on. He tells them, he sends them to a cardiologist, but I've not. And then what would you do? Stent? Put a stent in?
Yes.
Well, I asked him about that, my urologist. And he says it just really, there have been studies done, but it just doesn't really help much because these vessels are so tiny, and it's not like a coronary artery where you get one stenotic lesion that can be stented. So it doesn't, according to him, it does not work well.
Thank you.
Hi, Donna Green, RN. This is the second lecture that I've had the opportunity to hear from you, Dr. Jeffry, live, and I appreciate that very much. I would like to say something, though, about sexuality in general. I think that is a very an issue which is largely neglected still in our, certainly, schools of nursing and also in medical schools. And I think that in order to work with people successfully from a sexual standpoint requires that we as people become much more aware of our own sexuality and be able to accept that more fully in order to work more effectively with those that we have as patients, clients, whatever. And I think that is a very large issue. Having sexual intercourse can be a very satisfying kind of experience, but at the same time for many it is not. And I think largely, or some of that has to do with the lack of dealing with that overall issue as opposed to erectile dysfunction and just the act of sexual intercourse. Thank you.
Thank you.
Your advocacy of the PD, the inhibitors, PDE5 inhibitors, does that ever get recommended for instance, a male patient who comes in who does not have erectile dysfunction but has other markers of vascular disease?
No, this is not currently the standard of care in America to put men on.
Are there studies underway?
There are studies underway.
It sort of begs the question whether or not male endothelium is different than female endothelium and whether or not there is an application more broadly.
Very good point. I don't think male endothelium is any different than female endothelium. So I think a woman with coronary artery disease would benefit by daily Cialis.
And so is there, you said that the erectile dysfunction is sort of an early warning system for male vascular disease. Is there any analog for the female? I know the title of this talk is Men's Sexual Health, but it just sort of begs the question because you just, if we're agreeing that male and female endothelium is the same, I think that's an interesting direction for study to go.
Well, women have erectile tissue, but it's not quite as obvious as men's. So I don't know. There could be studies that could be created.
Doctor, I noticed in your book that you actually use vitamin E after your workout. But I've also read a study about the PDEs in 5 and using vitamin E as an enhancer. Have you heard anything about that?
No, I haven't. This whole daily Cialis phosphodiesterase inhibitor thing is a new thing. After my book came out, I've been working on putting this talk together over the last month, and Indopat has provided me with literature, and that just opened my eyes up to this. I just was blown away by the potential that this family of drugs can have on far beyond erectile dysfunction.
Well, there's a study done in Japan that was showing the enhancement with vitamin E and the PDEs.
Great. How many of you are here for the first time to one of these meetings? Wow, great. How many of you are internists or family practitioners? How many of you are surgeons? How many of you are cardiologists? George, have you ever considered using the daily Cialis in your patients? Have you had good results? Have you seen an improvement in their exercise tolerance? But would you is that common that cardiologists are doing this, or are you just one of those rare birds? Rare bird. Should have known that. I think that's it.